Nu skal jeg lige se en gang her, hvordan man gør det.
Ja, det er det.
Ja.
Hej.
Hej. Det er fordi, vi flyttede mødet, så taber vi.
Ja, men ved du hvad, det er rigtig godt, det bliver optaget, tror jeg, fordi så kommer det ud til endnu flere, ikke?
Ja.
Og det kan jo også godt være, at der er nogen, der ikke kunne på grund af det flyttet, ikke?
Det ved jeg, men jeg ved også, der er nogen, der har skrevet, at de ville komme.
Ja.
Thomas, han er nok den mest oplagte. Hej Thomas.
Hi, how are you?
Very good. And you're the one who preferred in English, isn't it right, Thomas?
Yeah, that's right. Yeah.
Good. So you get your way today.
That's good.
You probably know we had to change the date because Heinrich had to travel, and I think we lost 10 people here in the process. So
oh God.
So we are recording it, and yeah. Heinrich, I'm sorry to say, but I think we lost 10 people because we had to change the dates.
Okay.
Yeah.
It was Monday. Was it originally?
No, they were 1 week ago. You know, just you had to travel.
Yeah,
So,
that was the.
Yeah.
I was invited to United Arabian Emirates.
Yeah.
And you won't believe it. At the opening session, they gave me a wonderful award, a lifetime award for all my things I did in my life. I felt like a dirty boy being splashed off with some hose and being clean, because it is not really just it's a little bit of doing, but somehow they appreciate it to do it now, and that's it. Okay.
Yeah.
Okay. But by case, I have a Danish paper, a Danish young man in my practice right now.
Yeah. Okay.
He's treated and for the second round.
Yeah.
And he's one of those cases who should come for radiation, because otherwise he's young and he would be endangered. Okay.
Okay. We just had 2 more. JF, welcome JF.
Yeah.
Yeah. And we have Thomas. I don't know if it's Thomas who's already engaged with you.
No. But Thomas is probably in the mid-30s, or?
Yeah. Okay.
I'm 30.
30? Okay, so I'm not too wrong.
No, you're good.
You look pretty young. Okay.
Yeah.
My sons are between 33 and 42.
Okay.
Okay.
Very good. It's a nice age. Then they.
Shall I start, or what?
Yeah, I think so. I just want to say welcome to everybody, and I'm especially happy to have Heinrich Seegenschmiedt with us here today. He is one of the pioneers in trying to do something about Dupuytrens in the early stages. And I can tell you that the last week I tried to visit the Danish hospitals in the capital area, and it has been an interesting experience. I just wanted to leave some brochures for the Dupuytren Forening here, and it was very differently received. This was, of course, at the surgery department. But yesterday I managed also to get some information flyers to hand it over to the radiologists. But it seems, as I already told Heinrich, and we have put it on the website also, there has been one publication in Denmark since 2015 on Dupuytrens, and internationally there has been 15,000. So nothing is happening in Denmark in terms of any research, and with the help of Heinrich and other good people in the World Dupuytren Forening, så har jeg prøvet at kontakte alle mulige læger, der havde været i kontakt med Dupuytren, but there is nobody active today. Nobody. And all those I contacted, Heinrich, they said either they lost interest or they got retired or they're not doing it. So there's a tremendous task ahead of us to trying to, how do we actually stimulate somebody to do it? But I think one way is to try to do events like this and show maybe to the Danish medical society that there are somebody trying to do something, and there are patients who are eager to have better and more treatment also in the early stages, but also to get more research done on the reasons why do we develop this. But welcome, Professor Heinrich Seegenschmiedt.
You can say to me, Heinrich, that's no problem. The situation you described was about 25 years ago with a German patient called Wolfgang Wach. And he was involved, I was involved, he approached me, he had read something about it, we had no internet. And at that point, he was very interested and asked, can I do something about it? And I said, yes, you can approach patient and you can make a so-called Selbsthilfegruppe. So let's say a group who joins together, and I will be a doctor, but we should also have a surgeon in it. And it started the initiative where patients, doctors of any discipline who are involved would integrate into one group. And this was the German Dupuytren Society, and it was the International Dupuytren Society as well. And this was then 10 years later followed by the International Dupuytren Society meeting, which took place in Miami. And I helped them to have the whole meeting being brought into a book. And from then on, we had not Olympic Games every 4 years, but every 5 years, the meetings. And last meeting was just in Brussels, where we met. I met your group leader, and I promised that I will be supportive in any means to help you in your country to set up something similar. And you are more or less the major people. You are the ones who are affected, and you have also to look for physicians who would also like to be shared this knowledge, because it's partially no knowledge, not being trained, and it's partially also not organized. It's all in whole Scandinavia. The same problem exists in Norway, exists in Sweden, and I have several patients coming from Norway and Sweden to my side to be treated. I right now have a young man in my place who belongs to the more risky group, who, for example, he is a climber, he is doing some mountain biking, and this is a risk for the hands. But I also thought that I would like to address today something about the Lederhost disease, which is similar to the hand palm. And just seeing that it's Lederhost is in foot and in the hand. There are also other diseases associated with this. So it's a whole family group, and one who is affected maybe, let's say, very sad that he has it, because it has a condition throughout his life. And that's important, because if you are examined by a hand surgeon, you will not be examined for foot. And if you go to a podiatrist, you will never be examined for hand. And we as a radiation therapist know this fact for over 20 years. We will examine and question and look for any site which has possible effects. That is important. So I'm starting now my lecture, which I have also given last year to the ASTRO, the American Society of Radiation Oncology. Maybe it's a little bit too scientific, but you can question as well. Okay, you can stop me at any time. You can question, raise your hands. Okay, so I'm now trying to go to the next slide, and it's working. Okay, there is a lot of readings about it. In the left side, where you see my mouse, is the German guidelines. We have developed since 2012, not only for Dupuytren, but also for osteoarthritis and for tendinitis, guidelines how to treat. And in whole Germany, we have about 100 to 150,000 treatments every year for this type of non-malignant disorders. I have collected all the data in a book, which is now outdated. It's from 2008, but you find any indication from the eye to the foot to the hand enclosed in this hood. And this is the publication I mentioned from 2010, Dupuytren disease and related hyperproliferative disorders. Hyperproliferative means proliferation is all when you heal, when you grow, and so if something is injured, also needs to have some growth, but this growth is pathologic, and it may overgrow over the limits, and that makes your nodules. And I'm working in the DEGRO and ERGIA group, which has more than 30 practices in Germany. I'm right now sitting about here in Schwäbisch Gmünd, yeah, where the arrow is, but I've also worked in Osnabrück, I've also worked in Duisburg, and I'm a so-called flying doc, and I'm mentoring young doctors to get involved in these practices. Then I show you 4 different persons. This is Mr. Dupuytren. He's about 200 years ago. He was the main physician of Napoleon, and Napoleon gave him a lot of victims because of the war. They had hand injuries and foot injuries, and Dupuytren was very ingenious to invent prosthesis, and also was ingenious in inventing some certain operations. So he performed the first fasciectomy, yeah? And he described the disease. Also, it was earlier described. Then Archibald Edward Garrett was an English person, and Lederhose was a German person. And they all described around 1890, 1817, the first diseases. So they are having and carrying this name. And Mr. Perroni was much earlier. He was already in the beginning of the 18th century. It's right down here. He developed and he showed that the penile corpus also has fibrous tissue. And if their growth exists there, the penile can be curved. And this is a disastrous disease because it enables the male for penetration and having intercourse. And if it's in a young person, it's really some bad disease, which should be as early as possible be treated. So I'm questioning always male men, and there's about 8% being affected. And if they can talk about it the first time, it's right like a relief, because it's always kept as a secret and they're ashamed of it, but it is one of those possible conditions. And other conditions may be a frozen shoulder. This is something which goes early before you can have Dupuytren. It can go back parallel. And also the protrusive scar, so right in the face and in the upper body is happening, or in the earlobe. If you put some earring in it, it can develop scars who are protrusive, look not very nice. And in an aesthetic approach, they are cut out, but they immediately occur and recur again, unless you would treat them with radiation. And radiation has the ability to stop these diseases. Here I show you, no, I have to go back. Here, I show you a situation where you have all 4 events. Here in the right hand, there's some development, and you see I mark out the cords in the hand with a double line. The nodules are marked with a line. And he has also some disease which develops into the fingers. And that is something which is very important, because if you not treat, if you just discover these nodules and treat them just with a small field, you will miss it in the fingers. And a missed and a wrong treatment is not a good treatment, because otherwise to make a treatment for recurrence makes it very, very difficult. I have done those cases which have been treated too early with a too small field, and they didn't keep the long run, the long perspective in mind. So this is a typical field, actually, avoiding the carpal tunnel, yeah, which is also, if you have here some fibrosis induced by radiation, it would be a bad situation. So radiation can induce carpal tunnel syndrome. So you have to keep this out, and not treating this area would also preserve the thumb muscle, and this would be preserve the hypothenar, so the little finger muscle. They have not been treated. It's rarely that you have some disease, and it has not been to be treated. But the fingers, they can curve and they can cause a contracture, and that is important. The same happens here on the foot. That's not a simple case. It's already an advanced case. He has skin involvement and has more than 1 nodule. So it's already stage 3. Yeah? This, on the other hand, is a blank foot and nothing happens. And in the hand, you can also see there is not significant treatment. So it just goes for treatment one hand, but you can leave the other hands and the foot not treated. That's important because they may come up later on in life. So you keep a long-term follow-up as a radiation therapist. This is the various reasons. For example, there's a family situation. Usually there's a male to female ratio of 3:1. So male are much more often affected. They are earlier affected with age 50, increasing risk. Females are with age 60 more affected. And it's especially the northern countries. It's called the Vikings disease, because of the preference of the northern countries. The North France and also Ireland are much more affected than any other parts in Europe, and in Asian it's very rare. Then the occurrence is usually between 2 to 5% in the population, but some areas have up to 20% prevalence in the disease. And you have always to be warned if you have 2 or 3 things in the same age, like if you have some Garrett's pets, which are here on the not on the inside but on the outside on finger joints, and have also frozen shoulder or pain disease, you are more likely to have an aggressive type of treatment, and you should be earlier treated. That is the map I usually send if a patient wants to get contact with me. He writes me, I write back, send me your address and your cell phone, and I send him some documents back. He fills it out and he requests a video consultation. Because I think with video consultation, you can get some good approach and get some sight, and I can make certain tests which make it very easy to detect and answer the major question to treat or not to treat, like Hamlet, to be or not to be. And if you need treatment, then you could come to the practice, then it makes sense. But however, many patients in the COVID phase, I had many video consultations, and about 35% of this consultation were too early, and had to convince them that the 2 nodules are not significant. And the situation of too early is very important because otherwise you would treat too many patients. There are 50% patients usually who develop some nodule will not have been treated in their whole life. So you can have, and that is my requirement, I at least require 3 to 6 months from the first consultation to the next, and give some advice what to observe and what you can measure. That's important. The risks are diabetes mellitus, and if you have some chronic concussion, this is typically the mountain bike driver or the climber they have affected. Usually it was people who have a jackhammer vibration on the force. So they have mini trauma, but the mini traumas result in an effect. And also there's some disease which is called Raynaud's disease. Raynaud is not the car, it is other written. It is a disease where the arterial perfusion is clamped off, and these people have in summertime very cold fingers, and the finger become whitish. So it's a shortage in oxygen perfusion, and that may be the reason. The same occurs after a fracture of the lower arm, and it's a long time cast causes some either chronic repetitive pain syndrome, but it can also cause Dupuytren. So there is some relation between trauma, long-term having the immobilization, and then occurring Dupuytren within half a year or up to 2 years after the situation. Then a situation calling some fibrosis anyway in the liver is cirrhosis, which is the effect of massive alcohol drinking. And so we recommend usually to just skip any alcohol and also skip nicotine. That is important. And when you have a father or a mother affected, then usually you can look for the grandfather, and in your line you have 2 or 3 generations, it is inherited. So even if you then have children, they maybe also want, and so that is important that you inform your relatives as well. And you see the situation. that is somebody, he's coming, having prior fasciectomies, so he had this developed, and so you see this thing is 90-degree off, so very advanced. I would not treat this patient because that is not curable for me. It's something for the hand surgeon. This is a situation where you see this finger is 90-degree. It's also out of the range of radiation therapist. However, the other hand, this is just 10-degree, slight bandager, would be not affected if this would be released. So one of the reasons would be, and I have done this with surgeons of trust, that they would cut the bandager out and stretch the finger to the position. You get a bandage, postoperative bandage, a cast to relieve this, and you should also wear this during the night. But then you have the old situation back, and we could treat this like a keloid with one treatment, and we could treat the rest of the hand like we would treat an early stage Dupuytren with 2 courses of radiotherapy. It is also quite interesting that we have done this, and you can have good results after the combined treatment. However, this is not recommended, it's not recognized, but it's some peer data which we have published in the American Society of Radiation Oncology, and I will republish it and update it, and will bring it to a written consensus, but it all takes time. You have also to test it. Go to the next slide, wait. This is the situation. It was a person named Luck, L-U-C-K, who described the different stages. And he described in the early stages some itching, some pain, some little changes, but no nodules. It was the inflammation. And this is early on. And when you develop your first node, you are already in a regression, in a healing phase, and nodules in cords, when nodules fuse together, become a cord, then the disease starts when you will detect it as a patient. Sometimes you detect it all of a sudden, but it's already there 2 years. But in this phase, you will present probably to your practitioner. He says, oh, you have Dupuytren, you can wait until it is curbed, and then you can be operated. That's the usual mention. However, you get at this time a bad message. You get a message, oh, you have to be operated, and you are afraid. You go into the internet, you see all these terrible hands. They get operated with scars, you see terrible operations, but you not see so much the option of radiotherapy. However, you may join groups, and they report about radiation. And you question about, you are afraid because they always say radiation is very dangerous and it should be avoided. However, you take any time when you have pain medications, and they cause in 1% deadly blood, let's say, bleedings. And with abusing, then you can have pain and kidney. And operation has an overall complication rate of 15%. So you ask maybe what is the risk in radiation? And I can tell you it's 0.5% in 30 years. So maybe the driving to the radiation therapist is more dangerous than the radiation itself. And have you ever kept your gloves on all the day on your hands? No, you have the hands always exposed to the sun. And so it's more likely that when you ever experience some cancer, it's a skin cancer, and it has been more exposed to the sun, which has 1% X-rays in any time, and you don't care for it. And then if you get radiation, you look in the literature, you have one single case which is published, and that is a questionable case because he has at the same time, on the other hand, no cancer. So it's questionable if this is a radiation-induced cancer. So we have no literature at all about radiation-induced cancer on the hand, beside the radiologists of early years who had an unprotected situation and were in large amounts being related to much higher doses than we ever would give. If a cord is developing, you can also slightly get your bandager, and we use bandages of maybe 10%, maybe 20%, at maximum 30%, because at 30 degree, the surgical indication starts, and we don't want to interfere with the surgeon. We are also not competing with them. We are just adding, yeah. So we're adding to each other by giving early treatment and trying to avoid constriction. The surgeon always tries to remove restriction. That is his goal. Our goal is to prevent. So our goal is more or less to keep the hand as normal as possible, but not to treat it too early and maybe unnecessary. So this is the important steps. And if you go beyond 30 degrees, you have to have operation. That is the ideal phase if you have, let's say, a straight hand. All fingers can be bent in normal way. You can stretch it normally. However, you have nodules, and you have shown in 2 consequent sessions that the nodules increase and some of your symptoms increase. Now, looking further, this is the staging. Yeah, N called the staging without any contracture. And 1 is what we introduced very early on, that we have cases up to 10 degrees which we treat. And then grade 1 is up to 45. Grade 2 is up to 90 degrees, but having a 90 degree bended finger is already making the use of this hand very unpractical. Yeah, just go into a, let's say, cup, or give somebody the hand for greeting. It's not really good possible. But that's the time of the surgeon, and it's the right time for the surgeon. However, if you just do a needle fasciotomy, you have 50% relapses after 1 year. If you go more invasive and cut the whole string out, you have at least 30% relapses after 5 years. So, and then more aggressive surgery easily results in wound healing, in complications, and also in sensitivity loss to some areas, because they have to cut out the skin and they don't replace it with the skin sometimes. They leave it open and it just heals with open, or they do some lipophilic filling. It is always more risky to operate than instead of radiate. This is showing you the sequence. That was my case. So inflammatory, just symptoms, just having these S for symptoms and pain. We don't see it. And if you would make it, I would just wait, and I would order to come back, let's say, after 3 to 6 months. Then you have your nodule. If you only have 1 nodule, then we just make photographs, we measure it. And if you then, after half a year, develop a 2nd and a 3rd nodule, it's a proven situation. But now comes in the tests which we can do. We can do a stretching test and overextension test, and you can see white discoloration in affected areas, but not shown with nodules. This is a very impressive test. We also measure the contour of the hand from the digit D1, this is the thumb, to D5, the little finger. We measure D1 to D4, and we also measure between the fingers, and this spread is compared with the other hand. And it's quite surprising if you make this to the patient visible. On the one side, the one hand, on the other, and you keep the thumb in the same level, then you would see how these hands would differ. It can be easily done. It's your personal map at the time you will be examined. It will keep your map throughout the life. And I have these maps in my chart. And the patient, if he comes after 5 years, I say, put your thumb exactly in the thumb contour and spread your hand, and then we can easily say it has the same stage or has been even improved, which you can prove with this. And we also measure the level, how we can lift the fingers from the baseline, yeah, from the top of the desk. That has never been done by the hand surgeons. They don't do measurements, and they have no objective values, which are important to prove that a disease is effective. They measure the angulation, but this is very late, and it's too late for us as radiation therapists to affect something. You can ask for functions who are impaired, but that's also not our stage. This is in advanced stages, and that is important. And this is showing you the measurements we are doing with a maximum spread. Yeah, D1 is the thumb to D5, little finger, D1 thumb to a ring finger, and this whole total spread from D5 to D2. This gives you exact values, and you can measure for comparison, maybe not every day, please don't do this. You can measure every month or every 3 months. And if you have a follow-up visit, we just compare these values and we make it very easy for us to say, oh, you are progressive, and then we have to design the field. I also encourage you also to make your lines which you have in the hand, the headline. Yeah? If you take this as a right hand position to you, that is usually the Columbia River going into the Pacific Ocean. This is the Delaware River going into the Atlantic Ocean, and this is the Mississippi going into the Gulf of Mexico. These three lines are important because then you can use the ray of the finger. This is the digit 5, digit 4, digit 3, digit 2. And then you can exactly describe above or below the line, and you can measure the course, and you can slide with your finger over this area and detect nodules which you haven't detected before. So N is the sign for nodules, C for course, A for angulation, S for symptoms, F for impaired function, and you have also pain. So these 6 criteria define the formula for progression, which I use all the time, and I'm treating patients since 1987. So it's almost 28 years, and I have seen now patients after 20-year follow-up, and I can really encourage you to consider this long perspective as your lifeline perspective, because in this time, many things can show up, and a radiation therapist will always help you with these things. Next patient, this is my formula. So you can get, you can see the nodules, and you see also the bones, and you will document your nodules, and you write in number of nodules, symptoms, function, and this is the staging. And so you see here clinical situation where you can really say, just a question. I can make it smaller, this image. Okay, so here you see first the outline of the field, the blue rim. Inside you see the nodules. Also you see interdigital space being examined, and this is basically shown a field which includes the basic part of the fingers as well as the hand, avoids the muscle of the thumb, avoids the muscle of the hypothena, and also not touches the carpal tunnel. These are forbidden zones. They shouldn't be treated. Also, the nail shouldn't be treated. So if you see any exposure of a full hand treatment, it's totally wrong, because you don't want to get 30 gray on the tip of the fingers, because it would make major changes in the nail bed. If you go now to some pathohistology, you can see all these elements, and there is something fibroblasts named and macrophages that are involved in inflammation, and these are the cells who can be determined in Dupuytren, but you shouldn't be really biopsied. It's a clinical diagnosis, and this is just what happens in the tissue. Now, this is the mechanism on the right side, and it's important. TGF-beta, the abbreviation accounts for tissue growth factor beta. It is the key factor for all cytokines. Cytokines are little elements which inform cell by cell about certain processes, but TGF-beta is like the fall maker in a waterfall. Yeah, it's the key symptom. And if we affect this with radiation, if it's stopping, it stops also the fibroblast and the myofibroblast proliferation. And you have to think on the hand, just is it a cut through? If you use auto voltage, you can use low energies, and you will address the tissue which is just the skin and underneath the skin. This area, which is the carpal tunnel area, and contains vessels, contains nerves, this is a non-target issue, and this shouldn't be treated. So usually electrons, which have the maximum in about 2 centimeter depth, so right at the bone surface, have the maximum here, and it's unnecessary to treat this area as deep. So auto voltage with a rapid fall off of the skin is probably the more ideal case and the technique to treat, and thereby you're treating only 5 to 8 millimeters in the hand, and that's the ideal situation. So not treat without both is totally wrong. I wouldn't say that it's a fault. And the same is true for the foot. However, these nodules are much bigger. This is Lederhosen. And if they walk on these feet, you can bear, they have really pain. And you want to get relief. And in this disease, really, we can observe shrinkage of the nodule and thereby also better function, reduced pain. And that was also the Netherlands study, which they proved, and it has now shown in a randomized study. So they give this free, Lederhosen, but they don't see the similarity. Dupuytren is not given free in the Netherlands. Yeah, this is a situation you don't want to have, but even this foot may not have pain. You have the nodules, and so you're in a dilemma saying, do you want to treat it, not treat it? I dissolve the dilemma because I say this is skin involvement, becomes red. The nodule are not just one, it's two, at least this nodule, but also this area is involved. So you have already a stage 3, and stage 3 I would always treat. Even if you have minor symptoms, this is a maximum symptoms. You could do something which is interesting. You could treat the left foot, it's on the right side, yeah, because it's looking at us, and just await the response here, because it's a systemic response which may also affect this other foot. So it would be most useful to use the effects which are not in this foot deriving. They come from the immune system and being brought to this foot area. At the same time, they could also appear on this side, and we call this abscopal effects. So if you treat one side, it may also affect other sides involved. So that is my newest approach, not treating both at the same time. You may have to come more often. However, you have the chance to get also response in the untreated foot. This is the way I design it. This is more at the edge. Usually, if you have the big toe, toe number 1, and the small toe as the medial, and the lateral part, and the other one, the central. So toe 2 to 4, central part. Then you have the toe area, the palm area, and the arch area. It's usually the toe and medium area which are mostly involved. And you can palpate this by bending the big toe and stretching and pulling the nodules towards you. And so I really like this examination, because it's really even small nodules you can discover by hardening, and so that's easy to detect. This is how I usually document. You have an area, it has been previously irradiated, and now these are new nodules and these are the old nodules. So you have to decide, after having received 2 series, you can also use a 3rd series. However, this should be done in conjunction with an MRT, that's on magnetic resonance imaging, and you're using the T2 sequence, and which shows that the already treated and scarred areas, nodules, will not take off the contrast media. However, the new nodules will take the contrast media in their nodules, and you can see them. So you can differentiate by MRI image older versus new nodules. And then you can decide to treat just this edge, and you can keep this treatment limited to the area, so you may avoid some of the full area to be treated. So this is a very complicated question, but we can answer them. And that's how we have measured a 7-year-old boy, which came 2 years later back, because I refused radiation in that age, and I have given the advice to go to a plastic surgeon, but he said, oh, don't get operated. However, a local surgeon cut that nodule out, and he came back with this big nodule, filling almost the whole heel, the whole arch area. And so I had to treat him. I get signatures from him, from his parents, and I informed him that he might get to have 2 pairs of shoes to be used and to buy for every pair he uses in his life. And then we treated him just with 1 series. After half a year in follow-up, he showed signs of total stability. Then after a year later, he showed some regression, and I kept on to wait for the 2nd series. So he came back after 20 years, and I looked up at him and said, how tall you are? He said 2 meters and 1 centimeter. And I looked at his feet, and he had a size 10.5. And then his mother said, he's not endangered by radiation. He's endangered by the gas pedal. Yeah? So it is quite interesting. I have already some follow-up which have beyond this 28th year, and it can guarantee you the radiation at a right time will have a long-term effect. And we have shown this in our study. We have 90% stability and even some improvement, while we have also failures in 10%. So we have not total resolution, however, a good resolution. Then this is the difference. On the right side, you see a linear accelerator with electrons. And this is a space left to place a bolus here. This is material which is added on top of the field. So the penetration depth is like a curve going up and then falling down. And if you have this maximum increase in the bolus, so not in the foot, you create the dose profile which enters with maximum dose to the skin and then falls off. So you can use additional material to put on top of this area to make it adaptable to radiation and to the ideal dose profile. But in auto voltage, it's a cone which you place directly on the skin, and you have directly the maximum dose on the skin, and you may want to have it, let's say, 5 millimeters deep, which is usually for the fit not as sufficient. You need to have maybe 2 centimeters. So knowing this from MRI or some imaging technique would be helpful to judge, to have the dose at the most depth which is reached. That is always important to detect this. It has to be detected by the radiation therapist to examine the patient. That's the testing which we make. Also, we just have lean the hand flat on the table, and then we press the metacarpal phalangeal joint. Yes, we press down, and then you lift your finger, and we measure this distance from the table to the top. And these measures can also be repeated, and it shows you the overextension. If a patient can overextend all fingers, I say, congratulations. And he says, why? He can say, because you have only Dupuytren disease and not Dupuytren contracture. Because contracture is all what goes beyond the flatness of the hands. So that is a very simple test to place hands against each other. If you can do this without problems, then you will also have to overextend it. So you can also put them flat together and try to extend your fingers. That gives you also some quick impression. Then this is a perfusion, that's not important. Then this is what I want to show between the first study which we published on 30 patients, 2003, and the Netherlands study in 2023. Almost 23 years were gone to come from some phase 1-2 study, which was showing effectiveness. And so I kept this knowledge and I used it for all my patients. I didn't think I needed a randomized study. And it took for the evidence making 23 years to bring in the evidence. And now it's taken over from the health insurance companies. However, we had at that time the same fee structure as we have here now. So we have not gotten a raise. That's why the treatment is so cheap in Germany, and it is much more expensive in the Netherlands. So that's just to show you. Then that's important. If this is the case, it might be too early to treat. Yeah? But if you look for the type of progression, you need 2 time points. Usain Bolt needs the starting second and needs 9.6 seconds to show that he makes 100 meters. However, this is not a run, your Dupuytren. So you have to make measurements at the time you present, and you have maybe the best measurement is after 6 months. If you would, let's say, have increased nodules shorter than 6 months, then you come also shorter. But usually a follow-up after 6 months gives you some idea about the speed and the possible dangers this situation has. Okay, you also see on this slide that there is prophylactic radiotherapy, so to avoid the situation, and this is post-operative radiotherapy. You have one finger banded, it will be operated, and after the operation, he will only one series to prevent the reluctance and the recurrence in this involved finger, but you treat the other hand like you would treat the prophylactically with 2 series. And the 2 radiation therapy series are usually 3 months apart from each other. This is what I want to show you. This is the target volume, very shallow. It goes into the finger, usually very rarely the proximal joints are in, the distal joints are affected, and you never ever should treat the nail here, the end joints of the fingers. That shows you the dose distribution. You see the immediate fall off with the auto voltage. So if you address 5 millimeters, that's about here, you have still 80%. And if you have it right here, let's say this is 5 centimeters, so that is about here, you're still in an increasing level. So you have to have the lowest energy used. You are still not having full dose at 2 centimeters. So you usually get the energy divided by 3, mixed it into, gives you the maximum. So a 6 MeV electron beam has its maximum at 2 centimeters, divided by 3. That is our schedule. We give in one series, the first series, 5 times. So every day from Monday to Friday, or from Tuesday to Monday, 5 treatments. For the Dutch people, we have something special. We give also one day 2 treatments. However, they have to be apart at least 8 hours. So if they come at 8 o'clock, they spend time in the city, and then they get the second treatment at 4 o'clock. That is possible. However, I wouldn't do it twice, so I wouldn't like to shorten the disease too much, as there may be much more biological effect. However, this is possible. So there's no really restriction to you have to treat on Monday and until Friday. You can also start on Tuesday or Wednesday, but try to have 5 treatments. That is the major goal. Then these are typical results. Delayed progression to surgery. This is the results, which is the control. In our study, with more than 600 hands examined, while we had, after 7 treatments with 3 gray, 12% in with only 7% recurrence in the 10 by 3 gray group. That was surgery. However, you have also progression not requiring the surgery. That is the control, which had not received radiotherapy. And this is increased disease control, stable disease in the other situations where you would irradiate. It's much better than this one. So it gives you a highly significant value for radiation being efficient to have increased disease control and having also delayed progression to surgery. These are detailed data that is not really important. Among the prognostic factors, it's really the staging, which would mean stage N1, so 10 degree, is worse than the usual stage, and it would be even more worse if it goes beyond, let's say, the 45 degree, because it shows you the more chronic and advanced the disease is, the less it can be affected. So this is the effects of radiotherapy, not to be brought in too early, but also not too late. And finding this solution can be done by a surgeon, by a radiation therapist who knows all these details. Then I go skip this is data. And so I want to summarize. Radiotherapy can be given in 2 series, has not to be given. We may delay the second series. 5 times 3 gray, a total of 10 treatments, which are usually separated by 12 weeks. So 3 months about. And then you also should have in mind that you might get post-interventional radiotherapy if you're at higher risk, having already a recurrence after surgery. Then you may want to have the healing supported by additional radiation to the operated finger, while the rest receives prophylactic treatment. So I would say that is my statement, and I would await your questions.
Okay, thank you very much. Thank you, Heinrich. I just lower my hand here. I have a question, and then I'll leave the floor for others also. But if you think that you are needed at least examination and talk to someone in Germany, what except of course we would call you, but is there a kind of society or group that you would advise? Would you go to the Dupuytren Society web pages and look for?
Yeah, you can go. There's a patient forum.
Yeah,
they have created many questions, and I have over 10, 12 years also collected my answers, and you can look at a patient guide, and you can put in the internet patient guide and my name Seegenschmiedt, and you find this. It's a 60 page document, which has been, and you can find it also on the Dart group, and you may download it also for your members. It's free, available in the internet. And these are usually my answers, and there are many questions, and I have tried to bring them together to small articles, and this is my advices in the Dupuytren forum, and I give also some advices in the Dart forum. I intervene sometimes if I see a very ugly field, and I say full treatment from the dorsum of the hand, which is just totally wrong, because they have to penetrate the whole hand, treat the whole tissue there to come to the surface. You should always be treated with the hand on top, yeah, with the palmar surface on top, and try to get dose fall off as rapid as possible. That is the optimal treatment.
I have heard that they have started treating Dupuytren in the United Kingdom also.
Yeah, this is Richard Schaffer.
Yeah.
He is, let's say, the promoter of the whole. He, since 10 years, he stepped out of the NHS and developed his practice, and he is right now working. I have to.
But I also heard that they might not follow the same guidelines as you have developed in Germany, and that there's been some not so good cases. Is
the nice forum. It's the official side of the health insurance. They don't say it's a situation, and they have also a referral system. They have go to the private and then to the family physician, and they get to have a referral. So Richard Schaffer is more or less 60% patients who are privately paying, and so patients end up with two hands treated with I think between 4,000 and 5,000 pounds. That is quite an amount, and have travel. We are a little bit more cheaper. However, we having also the fee structure, which is quite old, and I would always think consider 0.5%, let's say half of the patients involved with autism don't need treatment, but they have to be affirmed. And if they go through this testing battery and examination battery, which I can give with video consultation, that's completely nice, because during this video concept, they make their own map, and they can use this map, and they get my 3 selfies. I mean, self-consciousness, they know what they have. Self-reliance, they can make their own map, and then they get self-conscience. They get convinced what has to be done, and they can come back anytime. That is, I have to detect this during COVID, so I have these video consultations more or less since 5 years. I'm performing them.
Yeah. Thomas, would you have some questions here or comments to
I had so I'm Thomas. I'm Australian and Danish, and I'm living here in Denmark.
Yeah.
And I'm also a physiotherapist. So I had a lot of questions originally also about, like, is there any conservative physiotherapy or hand therapy treatment for this? Is my first question. Do you know much about that?
Yeah, I know something about this. Patients try always to stretch their hand at least half an hour, and they think they do something against it. However, it's more or less the opposite. If they use the physiotherapy, overstretch it, they actually activate the disease, and there's nothing to be done. What could be done, and it has been done after operation, can also be done at the early symptom situation. They can leave their hand in a relaxed position, usually during the night, in a cast, which keeps the hand open. Usually we are mammals, so we have to keep on the fur of our mothers to be carried around. So usually in the sleep we bend our fingers, and Dupuytren patients often report, oh, in the morning it's stiff. However, during the day can open their heads much better. So if they would have a cast, we have some X-glove or other. If they would always having the hands, the fingers pulled back a little bit, then they would use the whole time over the night, while they sleep, to keep their hand in a stretch position. And that is my let's say recommendation for them. Try to keep your hands, if you sit or under your buttock, you sit on their hand, try to have them, let's say, in a more relaxed fashion, not in a stretched position, in this flat position, and use this night sleep to have them put in a cast. That is more or less what you can recommend. Other aspects are important after operation. You certainly need hand therapy, which is important. But again, it's not clear if you would overdo what we do, because stretching is usually something which affects this whole healing situation and makes them even more responsive to fibroblast proliferation. In my mind, it's the only way of getting in one step the whole area involved, while if you invest into injections, you have to have at least 10 injections to cover all the nodules. So it's very convenient to irradiate the whole palm and affect this disease driving forces at best.
Okay.
Thanks.
What about you, Jan? You want to say something, ask questions, or I don't know about your situation?
Yeah, I can comment. I have a 45-degree bend in my pinky finger.
Okay.
So, and I'm looking for a treatment, of course.
On the right hand or on the left hand?
Right hand.
Are you scheduled for surgery?
No, I'm trying to see my options because, of course, as you said.
So if you would come, we know exactly you would have been operated. We wouldn't treat this hand. And unfortunately, the whole staging is regarding the most affected finger.
Yeah.
However, if you look at the other hand, let's say the finger 4 to 2, yeah, the ring finger is, and then the middle finger and the index finger, they are normal. And if the other finger would brought into a normal position by surgery, and if you have only cord and not really nodule forming, you may go away with just fasciotomy, which is a needle inserted underneath the skin, and just with some, let's say, skipping movements, you cut these tendons on these strings, and then you know you might have a 50% recurrence rate. However, if we then, after operation, would irradiate and have this concept with you, a risk taker, and the surgeon and me also as risk givers agreed this is our approach. We don't blame each other. We try it at least. And this has been done over 15 years. And I have more than 100 patients having some good results. Of course, they get only one treatment at this little finger in this area. However, they get the prophylactic treatment for the rest of the finger. And then they wouldn't, let's say, get some proliferation in the other fingers, which is usually induced by operation. So operation is not only inducing recurrences, but also induces a flare-up of the disease in the other fingers. That is the problem they have.
Yeah, because that was also what I had in mind, because I don't have any nodules. I only have the cord.
I have an excellent surgeon since 3 years, and I send my patients after they come to I make the assessment, I make the photographs, and then I mail him the photographs. And so I have my pre-operative assessment, and I give patient then the address and they just arrange to come to him. And he looks and he gives a date where he would do the operation. If it's just a minimal invasive procedure, we would treat within the same week. We would start. However, if it's a more extensive operation, we would await full healing, so at least 6 weeks, and then we would treat this area. But in the same way, just one treatment for the affected side, and for the other sides which are having the minor Dupuytren, we would give the prophylactic treatment.
Sounds very good. So how do I get in contact with somebody then?
Oh, you have to go. You just take my email. You write you want to have an appointment. Then I ask you to give your mobile phone and your exact address. I know you will not cyber attack me. Yeah? So we have some identification. Then I send you some forms which you fill out. And then we agree on a date, and that's it. And we have you video consultation. And during the video consultation, I exactly sign in what you have, and you confirm that is what you have. And we're making the testing, the spelling test and the overextension test, and we make blood perfusion test. And by this, I could also get some ideas which fingers I would treat. I haven't palpated them, so that is a little lack. However, I can make the basic decision to be or not to be. It's the Hamlet question. It's the Danish king, yeah? And so I can say to you to treat or not to treat. That is the question, yeah? And
Yes.
if certain criteria are fulfilled, it's easy to say, now you need treatment, yeah? And then you can decide still, people are advertising how they do it. I have been previously in Hamburg, that is very close by, but I'm not there anymore. They still make advertisement for the treatment. However, I'm a little bit more down, let's say 300 kilometers more in Essen. That can be done. And however, you're free.
Yeah, that's not a problem. So,
Okay, actually, you can look for Jan Christian Moslund. He was a Danish patient who has also made YouTubes, and you can find his YouTube about the examination. And I'm talking to him. He was the one who asked me, can I make a video consultation? And so we did this in a way that you can see what I will do and how he will be examined. That is a patient, and you should also exchange underneath each other and promote it. And you need always a testimonial. So one patient, maybe your prime minister has it and he will be treated and he will promote it. But you are yourself a famous. Okay.
Good.
Yeah.
Thank you very much for that answer.
Okay.
Okay, Jan, we also it's on the Facebook and on the web pages of the Danish Dupuytren Forening.
It says patient guide for
Yeah.
the patient with Dupuytren. Yeah.
Yeah.
Yes,
And,
yes.
Heinrich mentioned DART before, and I just want to say that it's a society that tries to promote radiation treatment, and it's also a
more or
place.
less patients, yeah.
Yeah.
It says Dupuytren Advocates for Radiotherapy.
Yeah.
It says DART, but that is also the little arrow you throw against, against something. It's a very good page. They have grown maybe close to 10,000 members, and you get a lot of reports and a lot of new people. But you reading all this information can be sometimes making you crazy. Some quieter groups like the German Society and your Danish Society maybe much more quiet and give you much more relief.
The DART pages are filled with stories. What I have this treatment, what happened next, and but it's a interesting place to go and visit. And I have seen, Heinrich, there are many cases from Australia there.
Yeah, that's new now. They have
that's
just
new.
recently detected, and it shows me, and I have met Jared Martin before he made his study.
Yeah,
I commented on his study and said you should make a quality assurance. Yeah, you should have this fields being read by others and give some advices. And he hasn't done it, and I've seen, and you have yourself seen in Brussels. A case where a finger was involved and they treated half of the neighboring finger and half of the other finger. This is really stupid because that's not really the distance makes it. It makes it the segment which will be treated. And so in the beginning, many mistakes can be made. And I myself made my mistakes and I've learned from the mistakes. And we should really look into solid people who have done at least let's say 50 treatments. If they have done 10 treatments per year and have done it 5 years, they have a knowledge of 50 years. They should have knowledge on follow-up. And these are the physicians you should address your hands, because you have your hands only once in your life. That is very important and very precious segment of your body. Yeah, you can't play too much around it.
Henrik, I can also add to the story that first time I got this. I could feel that something was wrong, and I began reading the big internet. I, of course, found your name and other people in Germany, and I actually thought you were still in Hamburg. So I got my treatment in Hamburg.
But so you got electrons, hopefully a bolus, and
it has worked fantastic. It's 4 or 5 years ago.
So initially they did no bolus, and
Okay.
I said you should have at least 1 centimeter bolus, and if they have done it, then it's a good message for you. They have at least followed my guidelines.
I'm sure that. But what is it with this bolus? Can you explain it in
Yeah, the bolus is like human tissue. Yeah.
Yeah.
And if you look at the curves, the penetration depth, it always starts at the skin surface.
Yeah,
So from centimeter 0, then you go to the right on the x-axis, and you would have at 2 centimeter maximum. So you start with maybe 65%, and then you have an increase up to 2 centimeter. And at 2 centimeter, you get a rapid fall off. So at 3 centimeter, you have only that 20%. So this is the distribution in electrons. While in the auto voltage, you have already 100% immediately on the skin surface. And then in Lederhosen, for example, you can say, I want to have the dosimetry at 5 millimeters. You can do this, so you increase penetration depth. However, I want in the head only the penetration depth, and within, let's say, 1 centimeter, the dose is really fall off to, let's say, 30%. So you affect much lesser, deeper tissue, and we don't cause any consequence or, let's say, side effects from that. And I was surprised that this Australian study, a total reported about 40% complications. That is unusual high. I had maybe 20%, and that's much lower. And I think that's due to the techniques they used.
Yeah. So can you just? I think we need to end up now here before people will leave us. But the German guidelines that you have been involved in developing, are they the official German guidelines, and should other countries use the same ones?
We don't say they should use it.
No.
They can read again. And I'm in the ASTRO now, in the ASTRO board for non-malignant diseases. They are using the word functional radiation medicine. That was my proposal, to use medicine, because that's better than radiation oncology, because that is not non-oncological diseases. So they have a process in which they try to integrate all knowledge and will write in, as I hope, international guidelines. So they will be endorsed by ASTRO and ESTRO, and I think also DECRO will being one which is giving their agreement. However, we couldn't say that the German guidelines are the international guidelines. They have just developed, and I'm the author, but I should not say I would have these guidelines exactly point by point taken. They should undergo the full process, and they may set other weighing points. For me, it is the standards I would apply for me and for my patients.
Okay. So, thank you, because I'm trying to, I can talk to you about that later, but I'm trying to see if I could get some Danish radio oncologists to have some interest in.
And we could have also the same type of presentation and question and answering. You can also invite, let's say, family physicians, because they're important. And I can point out more the advantages of treating early. This is instead of having the patient waiting and getting this disastrous situation for himself and not knowing what to do.
I think that's okay. Thank you. Are there more questions or comments for Heinrich here? Dorte?
If you like, you can set up another meeting, so the rest of the 10 which we lost can still join.
Yeah,
make it more question open.
I think on the other side of the new year,
Yeah,
I'll set up.
Good.
But let's find the dates and announce it again. Thank you very much to everybody.
Goodbye, my dear.
Bye. Bye, and thank you for the help, Heinrich. The presentation would hopefully be online.
Okay.
Let's
see
if the technology works. Bye to everybody.
Bye-bye.
Thank you, Thomas and Jan and Dorte.
Thank you.
Thank you.
Bye. Just